Hello, everyone. This is Jim Moeller. I am the director of the Sports Medicine Fellowship at the Henry Ford Health System in Detroit, Michigan. This is a video series of lectures for sports medicine fellows. Today is part 2 of a series of lectures regarding the highs and lows of sports medicine, an introduction to altitude and diving medicine. Today's lecture focuses on diving medicine or undersea hyperbaric medicine. At our previous lecture on altitude, we talked about goals and objectives. Specific to today's lecture would be a review of physiology of exposure to low altitude, high pressure situation, as well as discussion of barotrauma injuries and illnesses associated with diving. When we talk about diving medicine, we have to talk about the equipment that's needed for people to do deep water dives. SCUBA, which stands for Self-Contained Underwater Breathing Apparatus, comes in two different forms. There's the classic or open circuit form, where the subject has a tank of compressed air on their back and breathes through a pressure regulator. The compressed air is at about 2,500 to 3,000 psi. The regulator provides ambient pressure breathing to the diver when inhalation is initiated. The first stage connects to the tank, the second stage connects to the mouthpiece. The flow of air matches the ventilatory rate of the diver. Expired air is then exhaled into the surrounding water. Because of the limited air supply, scuba is usually limited to around 200 feet of seawater depth. Now, another form of scuba which is becoming more popular with recreational divers but has been used by military divers for decades is the closed circuit scuba. In this situation, a rebreather is used, and that rebreather conserves inert gas by recycling the exhaled gas through a carbon dioxide absorbent and replenishes only the consumed oxygen component. When we talk about scuba and deep water diving, there are many medical contraindications, both absolute and relative, to this activity. Looking at cardiac contraindications, congestive heart failure and asymmetric septal hypertrophy and valvular stenosis is an absolute contraindication. I apologize for the spelling error. Stress testing is often utilized to determine readiness for diving in people with cardiac disease, and the suggested minimum criteria for stress testing is the ability to achieve 13 METs. You can see there are a number of relative contraindications as well. Looking at the pulmonary system, a history of spontaneous pneumothorax is an absolute contraindication to scuba and deep water diving. Active asthma, EIB or COPD, or history of the same with abnormal changes on the pulmonary function test is another absolute contraindication. Restrictive disease that does not cause exercise impairment is a relative contraindication, but exercise testing is necessary. And you can see additional relative contraindications on the right side of the screen. The ENT system contains a large number of absolute and relative contraindications. An open tympanic membrane perforation, tube myringotomy are absolute contraindications to scuba. And again, a large list of relative contraindications are also noted. Looking at the neurologic system, history of seizures other than a childhood febrile seizure, TIA or CVA, spinal cord injury, or disease or surgery with residual sequelae are all contraindications to scuba. Looking at the GI system, severe GERD, achalasia, esophageal diverticula, chronic or recurrent bowel obstruction are all absolute contraindications, where peptic ulcer disease, inflammatory bowel disease, and functional bowel disorders are only relative contraindications. And then there's a long list of other things. Pregnant women should not be doing deep water dives. diabetics on insulin should not be performing deep water dives. Sickle cell disease is an absolute contraindication, where sickle cell trait is a relative contraindication. So what is the issue with diving? The primary issue is increase in ambient pressure. If you remember Boyle's law, volume and pressure of an ideal gas at a constant temperature are inversely related in a fixed mass. And so what this means when you're looking at diving is the deeper you go, the greater the pressure, the less volume that you will have in that gas. And so at the surface, 1 atmosphere of pressure, you basically have the normal expected 100% gas volume. When you move to 10 meters of depth, you've increased to 2 atmospheres of pressure. And so your gas volume is decreased to 50%. And it's a simple math situation. 1 over 1 is 1. That's 100%. When you get to 2 atmospheres, it's 1 over 2. So you're at 50%. 3 atmospheres is 33%. 4 atmospheres is 25%, and so on. So the deeper you go, the greater the pressure that develops, the smaller the gas volume. So underwater pressure is directly proportional to depth. In a nutshell, if the pressure is doubled, the volume is reduced to 1/2 of the original volume, and every 10 meters in depth reduces the gas volume proportionally. Gas volume change is greatest when you are closest to the surface. So if pressure is the primary issue, then trauma due to pressure, or barotrauma, is the primary problem, and this can occur during descent when the pressure is increasing, or during ascent when the pressure is decreasing. Tissue in air containing body cavities like the ear and the sinuses and the lungs and the gut is injured due to pressure differences between ambient and body cavity pressures. And so pressure equalization is vital. Barotrauma can happen in a number of places, like I was just saying. The pulmonary system, in the middle ear, the inner ear, the sinuses. You can get something called face mask barotrauma and gastric barotrauma. Pulmonary barotrauma was first reported in an ascending diver in 1932, where it was found that inadequate exhalation during ascent led to overexpansion of the lungs. Transpulmonary gradients of around 100 centimeters of water can lead to rupture of the alveoli. Complications when gas from the lung escapes into the interstitial space and enters other areas is what causes the barotrauma. So when gas in the lung interstitial space enters the mediastinum, it causes mediastinal emphysema and pneumomediastinum. If it enters the pleural space, it can cause pneumothorax. Dissection along the esophagus can cause pneumoperitoneum. Dissection upward from the mediastinum into the soft tissues of the neck can cause subcutaneous emphysema in the neck. And with high alveolar pressure, gas can be forced into the pulmonary capillaries and enter the arterial circulation, causing gas emboli. Pulmonary barotrauma can occur in the absence of an evident overpressure event. Now, Harker et al. Reported on 31 patients with pulmonary barotrauma from diving and found that 25% of them had pneumomediastinum. Which you can see here. You can also see the subcutaneous emphysema, which was found in 10%. Pneumopericardium was found in 6%. And also pneumomediastinum in this particular case. Pneumoperitoneum in 3%. And then classic pneumothorax was found in 3%. In addition, pulmonary infiltrates caused by aspiration were present in over half of the subjects that Harker looked at. So pneumomediastinum usually presents as substernal pain worsened by cough or swallowing. A Hammond's sign, which is a synchronous crunching sound with the heartbeat during cardiac auscultation, is often noted. diagnosis is confirmed by chest x-ray and or CT scan, and the treatment usually resolves spontaneously, but can be hastened by the addition of 100% oxygen. Subcutaneous emphysema is air trapped within the skin tissue, usually of the neck. Air tracks from the lungs into the mediastinum and up into the neck, and the symptoms are typically mild but can include chest pain, a puffy neck, which I call a bubble wrap neck. If you've ever pressed on someone's neck who has subcutaneous emphysema, it feels to me like bubble wrap. Skin tenderness is also often present. Those are the mild symptoms. More severe symptoms can include respiratory difficulty, cyanosis, circulatory impairment, voice changes, and dysphagia, as the increased pressure causes a restriction of neck structures, including the carotid arteries. In mild cases, supportive care, observation, oxygen usually is going to be sufficient, but in more severe cases, hyperbaric treatment may become necessary. Looking at pneumopericardium, and again in this particular x-ray you see the pneumopericardium and the pneumomediastinum. The symptoms of pneumopericardium include chest pain, rapid heart rate, pain in the right upper abdomen, pain that extends from the chest to the shoulders and back, nausea, shortness of breath, fainting, drop in blood pressure may be present, and signs of shock, such as limbs that are cool to the touch and pale skin may be noted. The examination reveals hypotension, elevated jugular venous pressure, and distant heart sounds, which are Beck's triad, Hammond's sign, which is the synchronous crunching with the heartbeat that we talked about, and description of what's called a mill wheel murmur, which is a tinkling sound over a succussion splash. I can honestly tell you I have never heard a mill wheel murmur, or if I did, I was unaware that that's what I was listening to. And that's due to fluid and air mixed in the pericardial sac, leading to this tinkling sound. Pneumopericardium is often a medical emergency and requires pericardiocentesis and consultation with a cardiologist and cardiothoracic surgeon. Pericardiocentesis is draining the excess fluid or air with a needle. The pericardium may also need surgical repair, which involves a sternotomy. But again, for milder cases, a less invasive procedure called a pericardial window can be used, and this involves making a small incision in the upper abdomen and removing part of the pericardium. Pneumoperitoneum. Symptoms include abdominal pain, nausea and vomiting, and possible signs of peritonitis. The examination will reveal a distended abdomen, generalized tenderness, decreased bowel sounds, hypertympanic percussion, and they may or may not have respiratory distress. X-ray and CT scan are helpful in diagnosis. Treatment usually is simple in mild cases. If you take into account the consensus of conservative treatment of a perforated ulcer, patients with pneumoperitoneum localized to the upper abdomen who have mild symptoms and stable hemodynamics should be initially considered for conservative management with anti-ulcer drugs such as an H2 blocker or proton pump inhibitor, and stay under frequent and careful clinical monitoring. In doubtful situations, more aggressive treatment such as needle aspiration, laparoscopy, and laparotomy may be required for treatment. Looking at pneumothorax, the symptoms include sudden onset chest pain, dyspnea, tachypnea, tachycardia are also found. Exam findings include decreased or absent breath sounds, hyperresonance on percussion. There should be absence of tracheal deviation in JVD. The presence of those things would indicate a tension pneumothorax. Interestingly, pneumothorax is most commonly seen at shallower depths of diving. A small pneumothorax in a patient with stable vitals and who is generally asymptomatic can be treated with oxygen supplementation and observation, but a large pneumothorax that is symptomatic often requires chest tube oxygen supplementation. The most Serious complication, as we mentioned earlier, is embolization, and cerebral embolization is the most serious complication, which usually occurs within minutes after surfacing. Apnea, loss of consciousness, and cardiac arrest even occurs in about 5%. Less severe symptoms include hemiplegia, seems severe to me, stupor, confusion, visual disturbance, seizure, vertigo, and headache. Treatment requires emergent recompression in a hyperbaric chamber. The serious complications such as apnea, unconsciousness, and cardiac arrest are due to filling of the cardiac chambers and great vessels with air. Middle ear barotrauma occurs when middle ear pressure does not equilibrate with ambient pressure. Primary risk factor is eustachian tube dysfunction, either from anatomic variation, edema from allergies, or edema from an upper respiratory infection. The tympanic membrane displaces inward as the middle ear pressure becomes more negative with increasing depth. This can lead to tympanic membrane rupture, and then as cold water gets into that area, unilateral vestibular dysfunction leading to vertigo can occur. Valsalva during descent can equalize the pressure and reduce the likelihood of middle ear barotrauma. Inner ear barotrauma can also occur, and this is due to the inability to equilibrate the middle ear pressures in spite of repeated forceful Valsalva maneuvers. The Valsalva causes increased spinal fluid pressure and inner ear pressure, and when the pressure gradient between the inner ear perilymph and middle ear become large enough, it can rupture the round window or the oval window, and then you get perilymph leakage from the middle ear. Symptoms of inner ear barotrauma include sudden onset vertigo, which may lead to nausea and vomiting, tinnitus, which may become chronic, hearing loss on the affected side, which also may become chronic. And the treatment is an ENT consultation and consideration of surgical repair of the round or oval window. Barotrauma to the sinuses occurs during ascent as the pressure is decreasing and the volume of air is increasing. You can get vascular engorgement and vascular bleeding, and usually this is shown by sinus pain with or without epistaxis. Complications include bacterial sinusitis, but also with that increasing pressure, you can get compression of the maxillary branch of the trigeminal nerve. Trigeminal V2 nerve compression leads to infraorbital paresthesias, which generally resolve spontaneously within several hours. Face mask barotrauma is an interesting problem as pressure inside the face mask decreases with increasing depth. If you recall 8th and 9th grade science class, when you're talking about air pressure and how pressure moves from high pressure to low pressure, as the mask pressure decreases, then your face basically gets sucked into the mask. And this results in facial barotrauma in the face mask distribution. Edema, ecchymosis, conjunctival hemorrhages, retroorbital hematoma, all these things are possible. And this problem generally resolves spontaneously. It's known as mask squeeze. And again, it's when the face gets pulled into the mask due to the negative pressure within the mask. To prevent this, all you need to do is breathe some air out through the nose into the mask to equalize that pressure. And this is important during descent. Gastric barotrauma, which is basically air in the stomach, usually from air swallowing during diving, and this will distend the stomach. And when you ascend and the ambient pressure drops, that air mass will expand, leading to distension. It can lead to rupture and pneumoperitoneum. Symptoms are on ascent with GI discomfort, nausea, distension, and you'll find that on examination, the distension, the hyperresonance on percussion, and generalized tenderness. In mild cases, observation and gut rest will usually help this resolve, but in severe cases, nasogastric decompression and surgical repair of a ruptured viscus is important. Prevention is through releasing air on ascent. Decompression sickness is the classic diving medicine problem that is discussed, although it is much less common than the various barotraumas that have already been discussed. The definition of decompression sickness is a sometimes fatal condition caused by the release of gas bubbles, typically of nitrogen, as it leaves its dissolved form throughout the body upon rapid decrease in barometric pressure, such as that from rapid ascent during a deep dive. This is marked chiefly by joint pain, which may be accompanied in mild forms by fatigue, itching and burning of the skin, and in more severe forms by shortness of breath, chest pain, paralysis, and confusion. It's often known as the Benz or caisson's disease. For those of you who don't know what a caisson is, this is a schematic of a caisson, which is an underwater, watertight chamber which is used during underwater construction. The construction worker actually works inside that workplace, that workspace that you see on the left-hand side when pressurized air is being supplied in. And it's upon ascent after long periods of time in a caisson that many of these workers would develop the decompression sickness. Now, we've already gone back to 8th and 9th grade science with discussion of air pressure and Boyle's law. So let's talk a little bit about Henry's law, where the partial pressure of a gas determines the dissolved gas content of tissues. This was named for English chemist William Henry. So as ambient pressure increases, dissolved gas concentration in blood and tissues increases, and this is what you get on descent. And then as the ambient pressure decreases, such as on ascent, the dissolved gas concentration in blood and tissue decreases. You see this when you open a soda bottle. As the ambient pressure at the bottle opening is less than in the bottle, the carbon dioxide concentration in the solution degasses and comes out of the solution. Increased pressure at depth forces gases into the blood and tissues, and ascent, while breathing compressed air, causes tissues to become supersaturated. So as ambient pressure decreases during ascent, gas expands in the blood and the tissues. Venous gas emboli are usually the first evidence of free gas, and transmission through a patent foramen ovale leads to air gas embolism and increased risk of decompression sickness. The incidence is roughly 1 per 5,000 dives. There are various types of decompression sickness, with musculoskeletal changes being the most common type, where joint pain is the primary complaint, but osteonecrosis may also occur. Pulmonary vascular decompression sickness with free gas in the venous system can lead to chest pain, dyspnea, and cough. There's spinal cord injury which may occur, which is usually below the T11, T12 area with paresthesias, weakness, lower extremity paralysis, urinary retention, and potentially bowel and bladder incontinence. And then there's this lacy cutaneous form of decompression sickness called cutis marmorata, which usually resolves within 24 hours. The treatment of decompression sickness is hyperbaric chamber with oxygen supplementation, which usually minimizes the risk of permanent injury. Fluid replacement is also important. Nonsteroidal drugs may reduce the number of treatments needed, but it may not alter the outcome. The severity of injury and time to effective therapy does affect outcome, but treatment even several days after the injury has demonstrated efficacy. For most cases of decompression sickness, hyperbaric therapy at 2.8 atmospheres lasting about 6 hours is used. So basically you want to recreate a situation where they are at depth again, driving the gas back into the tissues for a less rapid ascent, if you will. The 2.8 atmospheres is equal to about 60 feet of depth. As I said a moment ago, hyperbaric chamber is the treatment of choice. And if the diver uses air as their breathing gas, the hyperbaric chamber can be used with free air. In most cases, however, oxygen is supplemented during hyperbaric treatment. Nitrox, which is enriched nitrogen-oxygen mix, or heliox, which is an enriched helium-oxygen mix, may be used for treatment depths greater than 60 feet of seawater. So a sample CAQ question. A patient wants scuba clearance. Which is true? A, an athlete with well-controlled seizure disorder who is on a stable dose of medication and has been seizure-free for 6 months is safe to be cleared. B, an athlete with previous spontaneous pneumothorax can be cleared for shallow dives only. C, an athlete with sickle cell trait has no more risk of hypoxia than the average diver and is safe to be cleared. D, an athlete with myringotomy tubes in place for 3 months is safe to be cleared. Or E, an athlete with active otitis media, if treated with antibiotics, is safe to be cleared. Pause here and come up with your answer, and then rejoin when you're ready. The answer is C. Athlete with sickle cell trait is at risk to sickle if they lose their source of oxygen while diving due to equipment failure, out of air, drowning. But the low oxygen tensions needed to produce sickling would have caused brain damage long before red cells became involved. If you look back to our absolute and relative contraindications, specifically, we talked about sickle cell disease being an absolute contraindication to diving, but not sickle cell trait. If we go back to the question again, any athlete with a seizure disorder, as long as the seizure was not childhood febrile seizures, is contraindicated for scuba. Any athlete with a previous spontaneous pneumothorax should be disqualified, and especially at shallow dives, because it's at the shallow levels where pneumothorax is actually a higher risk situation. And then also myringotomy tubes and active infection of the ear were also absolute contraindications. So I thank you for joining me today to talk about diving medicine. I hope this lecture was helpful. If you have not already listened to the altitude lecture, I do suggest you go back and listen to that as well. And if you have any questions, you can feel free to contact me directly at jmoeller.md@gmail.com. And in the subject line, put Moeller Video Series Lecture Question, and I will get back to you as soon as I can. Thank you and have a great day.